In Smile in 3-Day technique, we use basal implant technique. To understand what is basal implant technique, we need to understand what is basal bone. So if you, this is a lower jaw and the mandible, and when you see this bone shape and size is being maintained by continuous stimulus from the muscle attachments, which are here, 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 and here, and here, and by the presence of teeth. Once these teeth are lost, this bone starts shrinking slowly. And once this bone starts shrinking, it doesn't mean the bone will completely disappear. This part will always remain because this part is still being maintained by muscle attachments and muscle movement. So actually the bone form is actually a function of or a result of muscle attachments and presence of teeth. Now a patient who has lost this alveolar bone, the bone which was supporting the teeth once this is lost, then this patient can still go for implants if the basal bone is engaged. So there is always hope for patients who have lost a lot of bone, whether it is the lower jaw or the upper jaw, because this kind of bone, whether it's in the lower jaw or in the upper jaw, wherever the muscles are attached, will never disappear. So if you see the cross section of the bone of the lower jaw, which I have been talking about, this is a cross section which we are seeing here now. And in this cross section here, this is just a diagrammatic representation. It need not be that these implants are so long, but the concept is that this implant, the basal implant, engages the thick cortical bone in this area. It could be anywhere, depending on the presence of the nerve and other vital structures. So a basal implant actually engages two cortical plates, this cortical plate and this cortical plate. And that is why these implants have also another name for themselves, which is bicortical screw. So when we have this kind of engagement of strong bone, it is possible to place the crowns immediately within few days. Let us compare this with a conventional implant. A conventional implant is just placed superficially, engaging only the top part, the top cortical plate, but going only halfway, little bit. It can be 6 to 12 millimeters long implant, or little maybe more. And this implant will be engaging only one cortical plate, will not be engaging the other cortical plate, and is only engaging that part of the bone which in the future may shrink. This is the major difference between a single piece implant, which is engaging the bone in the cortical area or the basal area, and a conventional implant. So now let me explain to you what happens when the bone shrinks with time, because bone will inevitably shrink with time because there is no tooth to maintain the stimulus to that bone. So this part of the bone will keep shrinking depending on different people's metabolism and their genetic makeup, and maybe other multiple factors. So because of that, the bone will shrink, and when the bone shrinks, the gum also follows it and will expose a part of the implant. Now the single piece implants are very favorable in this nature, in this situation, because their neck is smooth and polished, so it does not get infected, And because their anchorage point is here, it doesn't matter whether the bone is shrinking or not. Their main anchor point is this, the second cortical. Whereas when you compare with a conventional implant, their main anchorage point is here. That's why they have threads like this, and their neck is very wide because they want to engage this part. But with time, when the gum shrinks, this part is, the rough neck is exposed, and very soon such patients have to get the implant removed because of recurring peri-implantitis or implant infection. So you see here that the bone has shrunk and the gum has gone down, and this is the exposed part. And typically, whenever such a treatment, such a infected implant is to be treated, what they do is they smoothen this threads and make it smooth and polished. So why not have an implant which is already polished like this? Then there's another concept wherein some people are using tall basal implants, but actually they are conventional implants. So they are using a version of this implant but much longer, engaging the cortical plate like this, but still it is not a single piece implant. So it may be a basal implant. It is a misnomer. They are calling it a basal implant, but it was never originally designed as a basal implant. So these conventional implants are being used as a basal implant, and again they have the same issue of gum shrinking down and exposing this very badly designed neck, which is very highly susceptible to peri-implantitis once the gum shrinks. Let me come to how the basal implant technique, the idea of actually engaging the basal bone, allows us to treat many of the non-treatable cases. By non-treatable cases, what I mean is those patients who have lost a lot of their bone or their bone density is compromised, but because this cortical bone is still very hard and thick, it may not matter if the bone is little hollow inside, that is, they have a little the bone density is compromised, but still the cortical plates are still quite dense and enough to take the load. So in patients who have compromised volume of bone or compromised density of bone, we can still do a good restorative job of these patients by placing implants and engaging the cortical bone. In this typical case, you are seeing this is a patient, a very interesting case wherein this is a syndrome wherein the teeth have never erupted, and this patient only had 2 teeth. Now, in this typical condition, none of the teeth had ever been formed inside the bone, and that's why the bone was not stimulated also to for the to hold the teeth. But still, there is enough cortical bone, and you can see here we have put implants and engaged the cortical bone, that is the floor of the sinus and floor of the nose. And here in the lower jaw, we have bypassed the nerve and we have put implants throughout and given this a considerable good restoration. And the patient is quite nicely functioning in this condition. You are seeing this illustration of a smile in 3 days concept, wherein you are seeing 12 implants in the upper jaw and 10 implants in the lower jaw, supporting 14 teeth in the upper jaw and 14 teeth in the lower jaw. This is what was there in that. When you compare this with a conventional technique like a typical all-on-4, you will see that the 4 implants are just engaging bone from canine or first premolar area to the canine and first premolar area, and the rest of the bridge where normally we chew with the back teeth. The upper molars, the lower molars have evolved. They are big in size. They have multiple roots. The upper molars have 3 roots. The lower molars have 2 roots. They are designed in such a way to take heavy loads. So a natural set of teeth has molars which are big in size and have multiple roots, like upper molars have 3 roots and the lower molars have 2 roots, and they are placed in an area all the way back here near the fulcrum, the joint, and near the masseter muscle for chewing, so that good crushing force can be applied and these teeth can take that heavy load. So if you are not replacing these teeth, you're actually not doing justice to the patient. The patient here is just getting a set of teeth which are maybe aesthetically pleasing enough but are not functionally great. So all on four concept is able to only give teeth in the front, only the front teeth, front 10 teeth in the upper and front 10 teeth in the lower. And even if they do give something behind, it is more like a cantilever. Then there's a concept. So you see here an illustration which is showing bridge which is extending all the way back, but this is a cantilever and cantilevers fail. Whereas here you see all the teeth are supported, the back teeth are supported by the last second molar is supported by a pterygoid implant which is engaging the hard bone. So the all on four has now evolved. Now many people are thinking of doing all on 6 and even all on 8, wherein they are trying to put more implants so that they can try to give teeth in the back. But again, whenever we want to give teeth in the back and we want to give zirconia, we have to put a few more implants because the zirconia bridge is, we cannot have zirconia bridge with long spans between two implants. The span between any two implants should not be too much. So based on that, you need to put a few extra number of implants. So that's why we end up putting 12 implants in the upper jaw and 10 implants in the lower jaw. And then we cement the bridge on the implants. In my practice, patients who are usually coming to us are those who have lost a lot of bone or have had uh, failed implants and or failed bridges, and they're looking for again uh, again another rehab. So such cases are usually very challenging because already the bone is compromised. If it's a failed implant, we're removing the implant, and then the number of sites for the new implants is a little less and more challenging. But because of the basal implant technique that we are doing, we are able to still get enough anchorage for the implants and also still manage to give the patient a nice zirconia bridge smile. So you can have a quick look at some of these x-ray here. So in this case, what you see is the upper jaw bone is very less, and in the lower jaw, the bone is again very less here. You can see a lot of resorption. There is hardly any alveolus bone in the posteriors, and we managed to put implants in such a patient. And this patient has been wearing dentures for 40 years, and she was told that she's not a good case for dental implants. The bone grafting will not help her much. So these are flapless implants. We don't have to cut the gum. We just put the implants and without cutting the gum. And these are the zirconia bridges. And this is how it looks post-op in the X-ray. So this is another case. This patient never had teeth, and we have put implants. Again, the bone is very less and the bone density is also very less. And this is a typical normal case. So even normal cases, like 30% of the patients are like these, where they have very good, beautiful bone, and it's very easy to treat such patients.